So those which are at lower energy levels are arranged parallel to the main magnetic field, and those which have a higher energy they flip down and they are anti-parallel to the magnetic field. But however, when you calculate the net magnetization, it is always in the direction of the main magnetic field, which are using in the MRI. So this is called as longitudinal magnetization. Okay, and next, now there is an external influence. So you are using a RF pulse. So when an RF pulse passes through the tissues, what happens? Already we had seen there was a longitudinal magnetization. There were protons along the direction of the magnetic field and some were anti-parallel to it. So now when the RF pulse has intervened here, so what happens? The protons take up energy and they create a flip. So see here, there is a flip. It gains energy and there is a flip, and there is also change in the direction of this magnetization. This is termed as transverse magnetization. So I will show again here. So when there is a RF pulse which was along the magnetization which was along this direction, now transverse, now change its direction, there is a flip and change in the direction of the magnetic field, that is this is now transverse, and the protons which were out of phase now it begins to spin. Now it becomes in phase. So here you can see which was horizontal becomes transverse, sorry, which was vertical becomes transverse and it starts spinning around this axis, and the protons are now spinning in the same phase. All protons will be spinning in the same phase. So this is called as transverse magnetization. Now coming to the relaxation. So I already mentioned external magnetic field, the protons are oriented. Now there is a RF pulse, it is activated, there is a change in the direction. So now when the RF pulse impulse is cut off, the tissues has to relax back to their resting state. So whatever the events which takes place during this phase is seen as T1 relaxation and T2 relaxation. So here you can see when the RF pulse is cut off, the longitudinal transverse magnetization has to grow back, has to get back to their longitudinal. So this relaxation, the events, the energy, what happens during this phase, when you record it, it will show as a T1. And the same thing, I also mentioned that there is dephasing of the protons. The protons which were in phase, which were revolving around the z-axis, now it dephases and it starts going out of phase. So that which happens during that, so this dephasing is called as T2 relaxation. Okay. So again I repeat, T1 is the time taken for the longitudinal magnetization to reach its 63% of its final value. That is to reach 63% of the longitudinal magnetization. The same thing, why is this important? The tissues, for example, I already mentioned, we basically in MRI it depends on the protons. So structures like water molecules have more of free protons. So they tend to retain the energy for a longer time. They do not relax back immediately. So now when you record, the time taken for the transverse to longitudinal is delayed. There is a long T1. So because there is a long T1, and simultaneously for white matter, what happens? They have more of bound protons. So during this time, the time taken for the transverse to longitudinal is shorter compared to the water molecules in the CSF and water, the protons in the water molecules. So they have a short T1. The structures which have a short T1 will appear gray, whereas the structures which has a long T1, that is the CSF and water, aqueous, whatever, they appear gray in even weighted images. Here the gray matter, the gray matter will have a here. The gray matter they have an intermediate T1, so they appear gray. The same thing in an orbit in T1, because it is water and it has long T1, it appears black. But whereas fat has more of bound protons, so it doesn't relax fat. The region of longitudinal magnetization takes a longer time, a short time, so it appears white. Same thing in T2, it is the opposite. So now the defacing. In T2, we are dealing with the defacing of the protons. So because that in, I will get back here. So here we were talking about this defacing. So this defacing is T2 relaxation. Because water molecules now again have protons, free protons, the energy is more, doesn't relax back immediately. So when you can note down the energy at that level, they are more energized. So that will appear bright. But whereas the fat will appear gray because it uses the defacing early. So it appears white. Okay. Next we'll move on to how to read a scan. First thing what you should do in a CT scan is always check the patient particulars. At one corner you have the patient details and on the other corner you have the scan, what type of scan it is and what sequence, if it is MRI, will be written on this. And the next thing what you should see is your laterality. So here it is whatever is towards the left of yours is the right eye and which whatever is to the right is your left. So this is right eye and this is right orbit, this is right orbit and left eye, left orbit. Next thing what you should see, if it is a CT scan, you should you should see about the window. So again here, this is a bone window and this is a soft tissue. And next thing what you should assess whether it is a contrast or a non-contrast. So how do you tell it is a contrast? You should see the extraocular muscles and the vascular coat of the bone. See, this gets enhanced. So this is a contrast film. Similarly, here the extraocular muscles and the vascular lining gets enhanced. So this is a D1. In D1, this is a contrast film. But whereas here, it is not enhanced. So this is a non-contrast. And here it appears gray. The extraocular muscles appear gray. So this is a non-contrast. And next is your plane. You should again look whether it is a axial, coronal or sagittal has to be seen. And if it is a MRI, you should also talk about the sequence, whether it is a T1 weighted, T2 weighted, pan suppressed, flare, TY and stare. And finally, whenever you see a orbit, you tend to jump into the lesions, which you should not, you should never do. You should always go in order. You should check the walls, then you should look at the normal ocular structure. You should see for all the four walls. Then you should see the contents of orbit, and then finally you should go for a lesion, whatever is in the orbit. Then you should go for its description. So whenever you see a lesion, you should always explain it. You should look at its size, shape, and whether how well defined and its margins, whether it is homogeneous or it is enhancing with a contrast has to be seen. And this is a scout window. So what is scout window? There are a set of parallel lines where you would want to have an area of interest. So that should cover, that entire region should be covered by these parallel lines. Only then your scan becomes reliable. For example, if you have a lesion somewhere here and it is not enclosed in it, you tend to miss out that lesion. So this is important to look for the scout window. It will be right here at the on the right corner. You can see the scout window. And we move on to some of the mistakes, common mistakes, or rather where we fail to write a adequate proper prescription or a requisition. So many times what we get is we get a scan like this, patient with history of trauma, and we get a brain scan, and when you examine patient will have crepitus, and somewhere else they would have even told about they have a fracture. So with this minimal orbital planes, we will not be able to clearly describe fractures or whatever lesions in the orbit. So you, when you are as well when you are giving advice, when you are requesting, you please kindly you should look for a dedicated orbit scan, so that helps us to look into the details of the orbit better. And the next thing, what we do is a scan window. So again, many times what we have seen is patient coming with trauma, they get only an axial scan. So we don't have the coronal scan, so we cannot exactly comment on the superior and the inferior wall. And also we need a scan window for the same reasons I told. When it is fracture or orbital lesions, you could mainly focus it on the orbital bone window scans. Okay. And one more reason I can give you here, see, uh, when you see this, there is a fracture here, there is a fracture here and here. That is clearly appreciated here in a bone window. The next, plane of the image. So plane is again important because we need to know the exact location of the tumor. So we need to know the anterior, posterior, and also the superior and inferior extent. Exactly where is the tumor located. So for that we need to know the plane. You should know all the planes. Like axial and coronal should be advised. So here this is a patient who had a history of recurrent swelling in this medial canthal area for the past 1 year. When I saw this coronal scan, all I could see is there was a body remodeling here and there was a collection. And here there was a hypodense collection in the superomedial orbit. Same thing, when I looked into the axial scan, I could see a defect here and there was a mucosal, there was an ethmoid mucosal which was entering into the orbit. So here the image plane is very important. So when you write a requisition, you should also make a document on the image plane. The next, contrast. Contrast I've already told. Contrast, the tissues, different tissues will take up different enhancement. The vascular structures will take up again bright enhancement. So here we have a patient, fullness or swelling in the medial canthal, and here you see the same thing. But whereas the internal, there is no enhancement in the intrinsic enhancement is not seen, but whereas the periphery you can see an enhancement. This is a dermoid. The same type of lesion here, the same child, different childs with the same site of lesion, but the scan shows this. There is a bright enhancement here. So this is a vascular lesion. So you should always mention the need for contrast in your requisition. And here is a lady who presented with sudden loss of vision in the left eye. You can see a ptosis here, and there was an eye grade. When I saw the T1 scan, I could see T1 MRI scan, I could see a well-defined lesion, a lesion in the intracorneal space. The same thing when I went for a contrast and a back suppressed, I could see a lesion. You can exactly see there was an enhancement in the periphery, and there was a slight hypodensity in the center. This was a lymphatic malformation, which had bled. There was a lymphatic malformation which had bled inside and that had formed a cyst. And choice of imaging, whether we need to go for a CT or a MRI. This lady again, she just presented with diminution of vision in the right eye. She had no other complaints. Same lady, we had already, there was a CT, she had a CT scan with a, somebody had already given her a CT and she had already got a CT scan. So here, there is a lesion at the orbital apex, but beyond that I don't know further. Went for MRI, here you can see a hypointense lesion at the orbital apex in T1, and in T2 you are seeing a hyperintense lesion. You can see very well appreciate, well defined. Same thing with has a intense contrast enhancement. So this was a vascular orbital apical cavitous hemangioma. And next is your sequence. The sequence again, T1 weighted, T2 weighted, fat suppressed. And there are other sequences too. But here what I want to highlight is a non-fat suppressed. So you are seeing a lesion. The same thing here. You can very well, it is a fat suppressed, you can appreciate the lesion and there's a contrast given to and its relation with the optic nerve. So this also becomes important. And yet another example, here you are not able to differentiate the optic nerve appears normal, more or less normal, but except for slight thickening here. Same thing when you do a add suppressed and contrast, you can appreciate that there is a hyper intensity in this area adjacent to the optic nerve. And sometimes what happens is you may not get a representative image of what you want. So it is better to get a entire video recording and you can look into the lesion of whatever you want. And always you discuss with your radiologist. And how do you write a requisition? So everything, whatever I had mentioned, should be there. First is your working diagnosis. The next, which part? Working diagnosis, you will have a differential diagnosis that has to be put in. And then, which part of where is your interest? Whether it's a right orbit and left orbit. And rest, everything, whatever I have mentioned, size, thickness, the imaging plane, you need all axial coronal, sagittal, if it is a trauma, and then you need to know the tissue window. You should mention, if it is a fracture or so, you should have a bone window. If it's a soft tissue lesion, you should mention about the soft tissue lesion. Contrast intensity. And if it's a CT, you may need sometimes modifications. Like whenever you have a patient having a venous malformation, all you need some modification. They need to take image using a Valsalva maneuver and change in the posture. That has to be discussed with your radiologist. In MRI sequence, what do you need? Whether it's a T1 weighted, T2 weighted, or fat suppressed, what you want has to be mentioned in the description or in the requisition.
Thank you, ma'am, for shedding much needed light on orbital imaging. We have about 10 minutes for a question and answer session. So feel free to ask your question.
To identify right and left on sagittal.
No, sagittal we don't have like that. Usually they take the wherever the lesion is there, that side they take the sections. We don't have right and left.
So we can't make out if it's the right eye or the left eye.
No, they only take whatever, it's a reformatted one. So they only take wherever the lesion is there, they take that.
A lot of confusion. Then we send the patient with the CT, the neurologist says you should have taken MRI. Again, when you take MRI, he says you should have taken the CT.
It depends on your experience and your working time. So it is you the one who decides. Yes, of course, there are certain things which you need to discuss with them, but it is always to know better what you want, you have to take it.
My teacher used to tell, if you want to know the container, take CT. If you want to know the contents, take MRI.
Sir, said and done, it is for any MRI is the choice.
Right.
If there is no contraindication, MRI is the choice for any soft tissue lesion.
And on the coronal, the right and left is the same.
Yeah,
Comes on your left side.
It's the same.
Print is the right eye.
No, you will have your students right. At one corner, you will have your name, everything. So
Right.
whatever is that right, that is the right. Like whatever is your left hand side is your right. And whatever it's not like a head charting or your
Same as action. Same as action.
Yeah.
Posterior vitreous cells persisting at +1. 2 months old, high medical steroids over. So you give this 26, 27-year-old bilateral posterior uveitis.
So this is something like intermediate uveitis, what you're saying, where there is cells only in the
Posterior vitreous, again posterior vitreous, and they have some fluid floaters, not persisting floaters, and you see the plan, and maybe you see lot of cells, not much, maybe more placement has become one cell after all treatment.
Yeah, so the vitreous cells take a longer time to settle down. So generally they don't disappear off completely. If it is occasional vitreous cells, I would still watch, looking at the vision.
There are cells, one eye ±1, other eye +1 cells.
So if it is the vision is good, probably I will just follow up with the OCT and look for any macular thickening. If the thickness of the macula is increasing, they develop cystoid macular edema, then you have to intervene. You have to increase your immunomodulation. Whereas if it is because that vascular leakages, especially in intermediate uveitis, does not go off completely. You would still have a leak which is there. And nowadays we don't treat the leak; we just watch the macula. So if we would probably look at the vision, the OCT. If there is a serial increase in macular thickening, then you know your treatment is not enough. We have to step it up. But if it is going to be maintained the same way without much change in the vision or on the OCT, I would probably just do so.
How common is tropical pulmonary eosinophilia causing, sometimes the investigations are all negative. So do you like to give them a course of albendazole or DEC or something like that?
Are you looking at any particular phenotype or?
Nothing. No. They have this hazy vitreous. They have turbid vitreous, but you don't see vitreous cells on OCT. And they have like suicide 1 or 2 cells in the anterior. Everything is negative.
So it is something like an intermediate uveitis with a spillover.
But they have very turbid vitreous. When you see, you can make out that turbidity.
Exactly.
They have that floater. They have that discomfort. I recommend doing albendazole or something like that. Or
I mean, for the uveitis, no. But yes, if you have an increased eosinophil count, I think it would help that. But, it's strange, but we are seeing tinea. And this is something which we probably ignore in our practice. And many of these patients with tinea have this kind of intermediate uveitis. They make vitreous cells, and unfortunately, these patients are on steroids for such a long time, then eventually they become like an immunocompromised kind of status, and then they land up with retinitis, retinochoroiditis, and vasculitis. And if you look at the skin, there's such a disseminated tinea corporis infection. So I think there is an infection, and probably what you're seeing in the eye is an immunological reaction to that. And the minute you treat your systemic infection, automatically the entire thing settles down. So I think, intermediate uveitis is a broad spectrum, and any case in a developing world, I think you will need to root out an infection. And these are small things which we generally tend to ignore. So that is one. The second one is fuchs. So fuchs can come with a debris, what you are saying, and before they present with an iris pattern abnormality, they are actually treated as intermediate uveitis and just doesn't go. And only over a period of time you start seeing that mottled in appearance. So these are cases which are unnecessarily treated with medications. So I think to answer that question properly, I will do a fluorescein angiogram and an OCT. And if I see a diffuse vascular leakage, these are the cases which I have to follow up for a long time. And these cases also need to be followed up with your serial OCTs.
Indications for periacular, subfinar, transcellular steroids in uveitis. When do you think of giving these?
So if the posterior component, if there is a macular edema, now of course we are moving more and more towards intravitreal steroids. But PSD does have a role, as Dr. Nick showed very nicely in those chikungunya related or post-fever retinitis. It makes quite a bit of difference in reducing the subretinal fluid. So I think any posterior component uveitis with macular involvement, but always would be a posterior subcutaneous steroid or an intravitreal steroid.
Just about partially pregnant at these rule of penetration. because it's very difficult to manage if there's an infection there. Before steroid has been given, it's going to be very difficult. So please ensure that there is no infection.
About the infection part, any part of the body can cause the uveitis.
Anything can cause uveitis.
Many times they have a medical. Like I had one patient with chronic sore throat and you can recognize. It's coming with the repeated
Post-streptococcus intermediate uveitis is actually very common, and this is something which we don't realize, especially in children. They have a URTI, upper respiratory tract, and then you see cups of retinal vasculitis. Generally settles down by itself. They're self-limiting. Sometimes you need a course of steroids. So, I mean, any infection could affect.
Not an active infection, it's an inflammation or an immunological response. So both uveitis and derived in the basic root cause is the inflammation or an immunological response. Other day I had a patient came with the dialysis and they came like they wondered how to treat this.
Dialysis and also the material they use for the dialysis, the fluid, can cause an immunological reaction in the eye. So you will have to tell if you're seeing uveitis, especially post dialysis, you will have to tell the treating nephrologist to change the fluid. The type of fluid. That was common, I think, once we used to get from the same dialysis unit, we used to get a lot of patients with immunological reactions in the eye. And the minute we kind of put it across to them, they would change. We made a few modifications. It's possible.
Another is the overcross patient. The drugs, etoposide or something. Whether the drugs can cause
Rifampicin causes, but we don't use it that often. Rifampicin is basically a second line which we not no longer use.
The toxic uveitis or toxic.
The rifampicin can cause hypopurine uveitis. That is one of the drug-induced uveitis which is possible. But the other drugs, no. We are seeing more of ethambutol-related toxicity.
Yeah, ethambutol related. Patient came with the hand movement vision and he's on antibiotic and that's almost normal except there was a diffuse attenuation. I thought it could be a retinal body.
Yeah, this is important to pick up because they have changed the government guidelines now.
Yeah.
So earlier we used to give for 2 months as an intensive phase or 4 drugs, and then we used to make it either 3 drugs excluding ethambutol or it used to be INH rifampicin. Of late, what they have done is they are giving 3 months of intensive, followed by 6. I mean, the next remaining months is with ethambutol. They have removed pyrazinamide because for them the drug resistance is high. So because of the change in protocol, we are seeing a lot of cases of ethambutol related.
So then uveitis related to rifamycin. What is your experience? How long? Because this drug is important, we cannot stop also.
So
We
the first.
cannot stop. Rifamycin is important to personalize that.
So usually we coordinate with the pulmonologist, and fortunately you should coordinate with the pulmonologist who is on the same wavelength as you. And if you say, I don't need ethambutol, I think they should be in a position to change and give pyrazinamide or just INH or rifampicin. The problem is to find that group of rheumatologists and pulmonologists, and that is very important. So, fortunately now I think people have become more open-minded, including the government centers which deal with this. We had a lot of resistance with them because they would never treat ocular TB, but we have these IE index TB guidelines, and now ocular TB is an important thing which they have also started recognizing. So I think that the team which you work should be
I get a
should
lot of
understand.
patients from the government hospital, this refer for small things. So it is very difficult to interact with the patient and the doctor. There won't be PSC, there won't be any restrictions. And it will not be most of the it will not be pulmonary tuberculosis or there's some they are all antibiotics. Empirically these are the challenging things to change can.
Just a change of track. When would you advise a patient with uveitis needing a cataract surgery in a child and in an adult? Just for
It's always a,
it's a huge topic. I know.
it's a huge topic. Yeah. Adults, it's now because of the immunomodulation. Earlier we used to give a steroid cover and all that. Now we don't give a steroid cover unless these patients have granulomatous inflammation where you are going to expect a lot of inflammation. Like, for example, VKH or sarcoid. There are not all cases, but there are cases you know are going to give a lot of response post surgery. So these are cases which I would still do a PI even in this era, and I would still probably give a steroid cover. Or things are better now with Ozurdex, so you do them under the Ozurdex cover. Children is something which is always dicey, and I always have a problem with our cataract. Though I do cataract, there's always a conflict with the cataract surgeon to put the lens. And trust me, the JIA HLA-B27 group of children and those who have this granulomatous with the sinus tape, initially they show such good results with the immune suppression, but if you look at them over 10 years, it's a slow death. So we've gone back to keeping them aphakic with good immunomodulation, even in conditions like Blau, where it is so you're going to see these inflammations again and again. And they do extremely well, like 6/6 vision, 6/9 vision with aphakic correction. So still that IOL in the eye, in these cases for me is dicey because we do see a lot of cases where we have explanted the lenses. But in adults, except for the B27 which behaves very, they look so nice, quiet, but the minute you touch the eye, they come with a hypopyon, and it takes a very long time for them to settle down in spite of immunomodulation. So for me, the requisite should be, they should be on good immunomodulation, but sometimes you have to take them up for cataract earlier, and these are cases which I would cover with preoperative and intravitreal.
One patient.
Basically, incision by surgery in case you have a Down syndrome after you let come back, but you have the corneal side.
So usually we prefer the corneal rather than the scleral, and we avoid the areas of thinning.
Because areas of thinning sometimes will be most of them is in the temporal or the upward. And most of us are used to upward lesion or the upward lesion. We never have upward lesion upward. It's a common problem we face. If there is an inflammation in the body and
Preferably the corneal, preferably the corneal.
One more case, no? There's a patient who had operated. He's related to a doctor actually. So Toxocara was diagnosed in Bangalore. He's 45 years. So he had a posterior subcapsular cataract with a tiny key. So surgery went on smooth. I had to use iris hooks because it was a very small pupil. So Pico went smooth and IOL was placed. He was fine up to 2 weeks post-op. So once we started tapering the steroid, he developed a pupillary block glaucoma. So did a PI, it was quite turbulent. So then he did well actually. So again we tapered the steroids, again he developed the pupillary glaucoma. So what do you suggest in such? Should we keep them on long-term steroids or immunomodulators or
It's dicey for toxo because toxoplasma generally is basically an immunological reaction that you're seeing. Sometimes you send it for cytology, you see eosinophils. I think PGI used to do a toxocara antigen, so we've had a recurrent one sent to PGI earlier, but now they have also stopped doing that. But it's basically an immunological reaction, so either you treat them with local steroids or you put them on Ozurdex for a long time. You have to repeat.
he doesn't have active toxocarriasis.
Okay.
That is all treated.
It's just
But
a
post cataract surgery, he keeps getting this pupillary membrane formation. Every time you do a PI, you break it, it releases, he's fine.
So
Then
these
again he
are
comes
patients
back.
who have a low-grade inflammation, so they have to be immunomodulated. So we do see this in who are immunomodulated also, but post-surgery you land up with thin. So these are cases which you have to do a surgical PI and try to increase your immunomodulation. Otherwise you keep hitting and then the PI closes and again you have a Bombay. So these are cases you will know.
Better to give them
Immunomodulators, and if you can do a surgical PI, do it.
After all the good discussion, I just wanted to mention colleague doctors. Actually, recently we had a case which was referred to Max. The patient was referred for an ENT specialist, saying that the patient had some, what we call as orbital cellulitis. Then about 5 days he was treated in an institution, and then it was referred to us. And there was a collection in the middle, this one, right? And chronic diagnosis. Then I traced back what is the history like, how he presented. He, with a, what we call as orbital cellulitis presented, everything was really tense. He wasn't examined properly at that time. They asked for an MRI, and the MRI, it came as though it's a sinusitis which is coming into the orbit. Basically, he had what we call as lacrimal abscess, which has gone posterior. And the eye would have been saved with a incision drainage of this lacrimal abscess. That is what is important of taking history and a methodical examination. We could have saved this one. That's what happens. That's why I just wanted to tell the postgraduates and all those things. How you misled in a investigation or something like that. If you go for an investigation first and retrace it, rather than taking a proper history and examining the patient. That's why I wanted to highlight it, and that's what it's all about.
Absolutely correct, sir. That you pointed out very correctly that investigations, any kind of investigations, are only as good as how we interpret them. Unless we are interpreting them in the correct clinical context, they're no good. And the second thing is, whenever we see a complex case which has been partially treated elsewhere, it makes sense to put all the old reports away, examine the case ourselves as though it is a fresh case. So get our own history, own examination, and then start looking at the old papers. Would you agree?
Yes, that's what happened. Whatever goes of it, very few patients, they don't respond. At least, 30 years back, they come now with some Uvitis, so it takes almost any day. Those times there is no people, ECC, what I do is I see, they come, if I look at that, they have every but there is no symptom, no pain, so I think
Exactly.
except steroids and cause me, causes more, steroid is this same patient, we just did an endodesal ECS with our ENT colleague and clearing the sinus as well as the medial oculotomy and clearing the pus from that. The patient who has a very clear as a hand movement now at the moment. So intervention makes a difference and clearing.
Patient with orbital myopathy is imaging suggestion of thyroiditis, but the PFT is normal. How will you manage the patient? Based on the clinical activity score with blood, how will you manage?
Okay, so you're talking about orbital muscles are enlarged.
Yes.
Okay. So what are the other features? There are certain very specific clinical criteria for deciding whether it is thyroid eye disease or not. Okay. These were first enumerated by Bartley. Okay, it is eyelid sign plus one of the following. Only one of which is thyroid dysfunction. Okay, if there's lid retraction, lid lag, etc., plus either proptosis or enlarged
recti or thyroid dysfunction, like systemic thyroid dysfunction, then it is thyroid eye disease. Or on the other hand, if there is total thyroid dysfunction plus any one of the following, that would be proptosis, eyelid signs, recti enlargement. So it's not necessary that the thyroid levels are abnormal for you to label it thyroid eye disease. That said, this T3, T4, TSH is not enough to tell you whether this is thyroid eye disease or not. The most sensitive thing here is to do TRAP, TSH receptor antibody. Say 7 or 8 years ago, we just write thyroid, anti-thyroid antibodies, and most places they would do anti-thyroglobulin or anti-TPO. Now, anti-thyroglobulin is non-specific. Anti-TPO is specific for Hashimoto thyroiditis. If you are looking at thyroid orbiopathy or Graves' disease, you need to get TRAP, TSH receptor antibody. A, it is going to confirm whether or not it is thyroid eye disease versus orbital myositis. And B, even if systemically the patient has euthyroid, if the TRAB is positive, there's a very high chance that within the next 2 years, the patient will develop florid hypothyroidism. So it's both diagnostic and prognostic. And the third point is it is prognostic. If TRAB is positive, you may be anticipating a stormy course in the orbit. It's going to become more active. It is going to become more severe. So these are the three things. If all of this is negative, you don't have any eyelid sign, you don't have TRAP positive, you just have the muscle thickened, you might be looking at an isolated orbital myositis. Okay. And then, if we are talking orbital myositis, possibly the tendon is going to be involved, and there's going to be pain. And then we go into this whole set of investigations, AMA, ANCA, ACD. That's where we are going next. ITT4.
Track positive and positive is good, but the patient has no pain and active signs. Can you observe or
You sit and you sit and watch. You don't do anything. Okay, so unless there's active inflammation, there's no need to give steroids.
in case of recurrence? In case of recurrence, it is
No, it is thickened, but what is it doing to the patient? Is the patient having double vision? Yeah, so that is the point. Muscle thickening alone is not indication for giving steroids. Double vision is very much an indication for giving steroids. And like full dose right from the beginning. What happens is in a muscle thickening, muscle inflammation, if you give a low dose steroid and the inflammation is gradually coming down, what's happening on the other side is that fibrosis is increasing. And once the eye gets stuck in an abnormal position with persistent, constant diplopia, then it will go into split surgery, which is very difficult. So, hit it with all your strength right at the beginning.
Pseudotumor somewhere nearby. Pseudotumor rapid, sure, thyroid, pseudotumor, signs not very specific.
So, pseudotumor or orbital inflammatory disease usually will be of two types. With one which is inflammation is predominant, and the other one where the mass effect is predominant. So, like I said, thyroid eye disease and orbital inflammatory disease are close by. And in fact, thyroid eye disease is one of the orbital inflammatory diseases. But like we said, if we have an eyelid sign, if we have antibody positive, you're going more towards thyroid eye disease.
Any change in the involvement of the muscle, belly involved, tendon belly, or something like that.
So orbital myositis or orbital inflammation, which is also sometimes called orbital pseudotumor, is more likely to have the muscle belly as well as the tendon involved. And there will be localized congestion at the insertion of the muscle. There will be chemosis at that area. Whereas in thyroid eye disease, you have all muscles involved, more likely bilateral. It may be asymmetric involved. Whereas in a myositis, which is isolated orbital inflammation, it could be any random muscle anywhere. And it will be more commonly unilateral. If it is bilateral myositis, you are actually looking at one of the systemic conditions, either IgG4 related disease or sarcoidosis. I've even seen tuberculosis present like that.
I think in the interest of time, we cut short the discussions at this point, and maybe the further questions could be taken on that.
Absolutely. Okay, what your question is about euthyroid ophthalmic. What's the question, sir? Yeah. So one is to, of course, like antibody, the thyroid.
That must be positive.
That would be positive. And euthyroid orbitopathy, sometimes there will be subclinical hypo or hypothyroid. Okay. So earlier, people who have been treating it, physicians and endocrinologists, they say, oh, it's subclinical, you don't need to treat. However, now the concept is developing and most endocrinologists are into that area, saying that even if it is subclinical, we are going to treat it, and even the subclinical part, the abnormal PSH, also we are going to get back into the normal range. So it would help in that case to have a very frank talk with whoever is seeing your patient, the physician or the endocrinologist, that it's not just observation, let's get even the abnormal PSH back into the normal range.
Let's move on to the felicitation of our guest speakers with green eco-friendly mementos. I would like to call on stage Dr. Srinivas to give that a token of appreciation to Dr. Kalpana B. Melody. Ma'am, sir, please come on stage. I request Dr. Ratnamma to please come on the dais to present a memento to Dr. Roshni. May I please call upon Dr. Ashok T to give our token of gratitude to Dr. Puneet Suri.
I would like to call upon the stage a budding doctor, Ms. Suma R, to be felicitated by Dr. H.S. Mohan sir for securing the highest marks in ophthalmology in Shivamogga in her third year university examination. If somebody can correct it on her behalf.
would like to summon onto the podium our charismatic head of Vitreoretinal Department of Sankara Eye Hospital Shivamogga, Dr. Ravi Shankar, to deliver the vote of thanks and conclude the event. Over to you.
Yeah, hopefully it's been a good event today, and it's my privilege to thank the people responsible for the event, starting with CME would be complete or good without the speakers, and I'd like to thank the speakers, Dr. Karnataka, Dr. Gupta, Varun, Uvitis, for coming and enlightening us with their knowledge and helping us probably solve some of the questions that we see in our practice. MOA has always been encouraging us to conduct more such programs under the leadership of Mohan sir. So thank you, and we expect a similar sort of encouragement and support in the future to all the officers of MOA. Thank you so much. Sankara Eye Hospital, the Sankara Academy of Vision has been supportive through conducting the programs and various aspects of conducting the CAV. So thank all the office bearers, the management, Gayatri ma'am, Anita ma'am, the support staff, the people working behind the scenes. Thank you so much for helping us in conducting this. The figures behind this particular theory are dynamic registrars, Dr. Suchitra and Dr. Usha. Thank you so much for all the effort that you have put in this program. Our MCs today are Dr. Pratika and Dr. Shivamogga. Thank you so much. Very well done. Yeah, the adjectives very quick, superlative I should say, but still very well done. To Milmet for supporting this program, thank you. Cliff Embassy, I mean sorry. And last but not least, to all the members, seeing people coming from Chitradurga, from Udupi, thank you so much. I mean, this is the sort of encouragement that we look forward to, and that gives us more energy to conduct more such programs in the future. Thank you so much, everyone. Lunch is arranged. Kindly have. Okay, feedback forms have been kept on the table, so with the QR code. Maybe if you can scan it, it will take you the feedback form, and I request all of you to kindly fill in feedback so that will give us, on what we have not done so well this time, so that we can improve on it in the future. Okay. Thank you so much. Can you